This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
We're going to talk today about minimally invasive surgery of the spine. I've been doing spine surgery for about 16, 17 years now, and I can tell you that when I trained as a medical student about 25 years ago, the same operation, the same incision was made for virtually everything that we did. That was an incision about this big, regardless of what you were having done. Same incision, expose the whole spine, see everything. Well, that's changed enormously, particularly over the last 10 years, and certainly a lot expanding roles in the last 5 or 6. I'm joined here today by Dr. Todd Alleman and Dr. Ivan Cheng, who will speak on some different points here, but I'm going to make the introduction and talk to you all about some of the anatomy and the most basic, or the original microsurgical approach to the spine, which is to simply do a discectomy. What do we mean by this minimally invasive surgery? Well, basically, it's a concept that, so far as using magnification, using small incisions, using a technique where you try to spare the tissues and to be able to do either a decompression or a fusion to free up the nerve roots, to decompress the spinal cord, where we don't have an enormous incision, where the rehabilitation time should be less. But really, we're expecting to approach both diagnostic and therapeutic modalities so that you can use needles to give injections for diagnoses, so far as injecting the discs. That's one of the things we've done a lot of our research on here. And then for therapeutics, so far as freeing up the nerves, freeing up the spinal cord, and if the spine is unstable, if there are areas where the spine is collapsing or there's destructive lesions, to try to be able to reconstruct this over a short amount of time for the rehabilitation. Spinal anatomy, this is what you learn in medical school. Essentially, at the very top of this, over here, that's where your head sits, and then the spine comes all the way down in the thoracic spine, lumbar, sacral, and the coccyx, or the tailbone. Now, there's different parts to the spine. The back of it here is the spinous processes, the lamina, and we'll be using these words, so just trying to give you some geography here. These are the vertebral bodies. The back of the spine, this end here, is connected to the front of the spine by the pedicle. And this is just looking at the bones, and out of these holes is where the different nerves come out at different levels. The disc is flexible. It's a gristly material. The idea of it being a jelly donut, so it's sometimes used, or that the middle is full of jelly, that's true if you're 15 years old. By the time you're 30, the days of jelly are over. The inside of the disc is turned into a kind of crab meat substance, and that gets drier and drier as you get older. And a lot of the problems that you have in the spine have to do with this kind of natural aging process. What we talk about as a motion segment includes the disc in the front, which is what you see here, and the ligaments and joints in the back. And that's where the motion in the spine takes place. So the vertebrae, the bones obviously don't move, but it's the disc in between. This is obviously a very young person. You've got the disc with the, it's a cadaver specimen with the jelly-like substance inside. And looking out here, I don't believe there's any jelly left in the room. However, even as it gets older and more brittle, it still, in most people, serves very well, even though it becomes more and more like a crab meat substance and more tough. It, for most people, works quite well, although it's this sort of a degeneration, hardening of the disc, and brittle cracking of the disc, which probably accounts for a lot of the back pain and the arthritis that's developed over time. Inside the bones, starting up in your brain and coming down, this long yellow streak here is the spinal cord. And that's really an extension of brain tissue that comes down from the bottom of the brain and down through most of the spine. But that ends at about the top of your lumbar spine. So at the bottom of your rib cage, maybe a couple of inches below there, the spinal cord ends. And what continues down are the little rootlets that'll form the nerve roots on either side, which you can see over here. These are the individual roots leaving at each level. And then as you get them down towards the legs, there's a lot of roots that merge to make the sciatic nerve and the femoral nerve and the big nerves that go down to supply the muscles in your leg. For reference, the spinal cord is relatively fragile. That is, you can't manipulate the spinal cord much. If you push it this way or that way surgically, you'll create a paralysis. If you are in an accident and you have a disc or a piece of bone that ruptures back against the spinal cord, it'll usually kill it. On the other hand, the nerves that are leaving at each level, the nerve roots, and the nerves in the cauda equina are much more resistant, so they can be moved around some. But this is what makes problems in the cervical spine quite a bit more dangerous than problems in the lumbar spine, because the cervical spine has a lot of motion to it, but the cervical spine has the spinal cord in it, which is relatively fragile. It is not very resilient to injury. This is a picture of degeneration as it moves along. The normal disc with the jelly inside. As time goes on, there's decreased water in the disc. And then as the disc starts to collapse, you start to get bone spurs that come out along the disc. Bone spurs that come out along the disc collapses some. The bone spurs can go back to where the nerves are. You can get arthritis in the back, and this whole complex is arthritic here. And that's what normally impinges the nerves. And the arthritis, it can give you backache or back pain. And if it becomes quite arthritic, it can become unstable. So that if you see people's hands who have arthritis, you can see sometimes the joints are subluxated out. And that's kind of a natural aging thing. It's painful in the hand. It can give you trouble lifting things up. But you won't become paralyzed because your hand is deformed. On the other hand, in the spine, if you get that sort of arthritis and the bones start moving abnormally or subluxating, that is moving relative to one another, sliding off, you can have nerve injury. And that's why these are, although it's a similar process of arthritis, it is sometimes quite a bit more dangerous, and you can have nerve irritation or paralysis in the spine from an arthritic process. What things cause the compression of the nerves? Well, disc herniations. When the disc gets kind of brittle and cracked, the inside of it, the crab meat part, can spit out and lean up against the nerves. It's actually pretty inflammatory and it can injure the nerves. Stenosis is not a disc herniation, but stenosis means that the space available for the spinal cord or the cauda equina becomes progressively narrowed. And that's sort of, that's what people talk about with spinal stenosis. You can have it in the neck where the spinal cord gets compressed. You can have it in the low back where the nerve roots or the cauda equina get compressed. And in addition to having herniated discs leaning on the nerves, or stenosis, that is the arthritis leaning on the nerves, You can also have instability where the spine becomes unstable. So even though there's not a bone spur leaning on it, or there's not a disc herniation leaning on the nerves or the spinal cord, if the spine becomes unstable, the nerves can be injured within it. All of this is part of an arthritic process. There are other causes. You can have tumors, infections, trauma, fractures, dislocation, but really this is makes up most of the people who are seen in a clinic as opposed to in the emergency department. So very briefly, I'm going to start now talking about disc herniation, probably the most common problem that we have in the spine. You can have disc herniations all the way from the top of the spine all the way down to the sacrum. Wherever you have a disc, it can herniate. Well, most commonly, though, the disc herniations that occur are in the mid-portion of the neck or in the low back. There's relatively few disc herniations in the thoracic spine or in the upper lumbar spine. This is somewhat a good picture of what it looks like. This is the vertebral body in the front. This is the lamina in the back. These are the nerves coming down here, and this is the herniated disc. And that's a moderate-sized one. The colloquial of herniated disc is sometimes called a ruptured disc. There's a lot of different names for it. But basically, it's a protrusion or an extrusion that is pushing out of disc material that leans on the nerves. And in the United States, there's about 300,000 operations done per year for disc herniations. This is very common. You see that's about one out of 1,000 people will have that kind of a surgery in the U.S. Every year. And about half that number in the cervical spine. So it's pretty common, and these surgeries, there's a lot of different kinds of spine surgery, but herniated disc surgery is usually quite effective and works quite well. Now you can have very big disc herniations. This is an MRI scan, and you can see this enormous disc herniation pooching back out. As you remember before, the nerves are coming down in this white cerebral spinal fluid, and they can get pinched by this big disc herniation. In general, even with big disc herniations, people get better. 75%, 80% of people are going to be better in a few weeks. But sometimes people aren't, and it can be a long-standing problem, and that's where the surgery comes in. The evaluation, the MRI scan has taken away a lot of the bad things that used to be done, where you had to give milligrams or injections. There's no radiation. It's a very good test for disc herniations. One of the important things to realize is that you can't see a disc on a plain X-ray. So if you think you might have a disc herniation, or your doctor says, well, it sounds like you have a disc herniation, and you're wondering why they're not getting an X-ray, it's because you can't see a disc on an X-ray. The X-ray goes right through a disc. On the other hand, on the MRI scan, you can see the disc quite well, and you can see the big herniation here, whereas you can't see it at all on the X-ray. As I said before, most people just get better, and that's the good thing. If you hang in there long enough, if you don't have a paralysis and you hang in there long enough, most people will get better even if it takes a year or two. And there are some data that show it. If you see people who have surgery for a herniated disc versus people who have not, even in randomized studies, in people who don't have a serious paralysis. So if you don't have a serious paralysis, if you get surgery versus not getting surgery, what it looks like is that the main benefit from the surgery is that you get better much quicker. And in the studies that have been done, it takes the people who did not get operated on about 2, 3, 4 years to catch up to the group that have the disc taken out surgically. So if people don't get better in the first month or two, the option for surgery is there so that the duration of the pain down the leg can be much less. If you take MRI scans, you can also see that the disc reabsorbs slowly over time. Unfortunately, slowly over time really means slowly. That is, it takes 6 or 9 months for the disc to really shrink down. So that for people that have terrible sciatica, that's a ridiculous amount of time to wait. but it does go away in most people if you wait around. This randomized control trial that I had been talking about really shows that you really have to wait to about 4 years for non-operative care to catch up to the results of surgery in people who have severe sciatica that's gone on for more than a month or so. The non-operative treatment, most people would say, well, take it easy for a few days. It's not a good idea to be in bed for more than a day or so, especially in older people. Then start getting up and getting around. There's no evidence that specific exercises make this get better faster. There's no evidence that a specific pill makes this get better faster. On the other hand, taking pills often make you feel better while it's going on, such as the non-steroidals, like naproxen or Motrin. Some people will take narcotics. There are times when you can take a steroid, which decreases the inflammation of the nerve. That is a pretty good treatment. It has side effects, as you all may know, from steroid treatment. And one of the ways to avoid giving a lot of steroid to the whole body is to give an injection of the steroid right around the nerve. And that's sometimes called an epidural steroid injection or a selective root block, where they can put the steroid right on the nerve. It's not a very morbid procedure, but you can't take a whole lot of steroids over time. Not just Barry Bonds, but it's not good for you all either. You can take probably 3-4 injections a year before you pretty much have too many side effects from the steroid itself. In general, it's a temporary effect. The epidural steroids can make you feel better for a while. It doesn't change the ultimate outcome. That is, it doesn't make the disc dissolve faster or anything like that. But if you were going to have sciatica that was going to last, if we knew ahead of time your sciatica was going to last for 2 or 3 months, if a couple of injections would make you pretty comfortable during that time, it may be a good idea to take those. On the other hand, there are some reasons to go to surgery right away. If you have a severe progressive paralysis, it's probably, at least in the United States, it's unusual for people to just wait that out. You try to take the pressure off the nerve with the expectation you can make it better. The cauda equina are those the bunch of roots that are rootlets that are coming off the spinal cord, and they are somewhat more sensitive than nerve roots. And a compression of those can have you lose control of your bowel or bladder. And obviously that's a catastrophic problem, and the idea would be to avoid that by taking the pressure off there. People who have pain for too long, that's what failure of conservative management. If you've got, if you're a young mother and you've got several kids in the house, having severe sciatica is just impracticable for, say, well, let me wait 4 months to this get better. On the other hand, surgery can usually make it better in a few days. Or people who need to mobilize quickly like that, or people whose the sciatica just keeps coming back. The procedure that we've been working on here for the last 10 years and continue to try to refine is to take out the herniated fragment using a microscope. In general, these are looking down at the nerve roots at the lower part of the lumbar spine. There are a bunch of tests that are positive for this, and in the sake of time, I'm not going to go over that. But the diagnosis of a herniated disc in this area is usually not very subtle. If you fail the usual treatment, there are different ways to get down into the area where the disc herniation has occurred without making an enormous incision and without stripping a lot of the muscle and ligaments. And one of the ways we've been using recently is using a tube like this to get down. And there are various other ways to get into the spine by using retractors that do as little damage as possible to the soft tissues and the bone. The old days, this is a scan after the usual open discectomy. There's a lot of bone taken off, and what you're looking at here is a lot of destruction of the muscle in the back that comes about by making the big incisions. This area here is a much smaller area where the tube or a microdissection instruments can be put down. So those are the relative areas of tissue disruption in whether to do it with a micro approach or an open macro approach. The idea is make a small incision, decrease the pain afterwards, decrease the time that you need to spend in the hospital away from family, and get you back to work faster, assuming that's where you need to go. Microsurgery, pretty easy to learn. All three of us are evidence of that. We've all got it down. You don't need very new instruments and new techniques. This is a view with the microscope there. You can really see quite well. You can have depth perception with the microscope. You get excellent light because the light goes right down to where you're looking, as you can see there. Unfortunately, the microscopes are very expensive, $100,000 for this kind of an operating microscope. But you can see with a relatively small hole here, you can work right down and get to the spine, get to the disc. This is kind of what it looks like with this microscope draped off with the plastic. The disadvantage is you're just looking at a little part. It's not like in the old days where you could just go look around at everything. You're really looking down a small hole. That's it. You don't get to see everything, so you really have to know where you're going. You can use one of these tubes to approach it. You can use these small retractors. It's not clear that there's much advantage in one over the other. It probably has less dissection using these tubes. You need to use an X-ray to see where you're going, since you're not going to expose the whole thing. You take measurements, mark up the skin to get down, and make a relatively small incision. This is about 3/4 of an inch, and that's pretty usual for a herniated disc surgery. You use the X-ray to see how you get on down. You can put these tubes down so you can see right down to the bone, clean off the bone, and get the disc out. At the end, you have a Band-Aid. So for a big disc herniation like that, this is a short video. You're looking down that tube here to the, all the way down the tube, and you see oops. You're looking down the tube right to the spine. And I'm not sure this is going all along. And right there, that's the big disc herniation, that big white thing. And it's being teased out, bringing the blood vessels and the nerve root over. This whole thing, the whole field that you're looking at there, is about 3/4 of an inch. And pulling the nerve root over so you can expose the disc. And that white thing down there is the big disc herniation. And the idea is to be able to do this, put the retractor that just went down and pull the nerve root over, so you're just looking at the disc herniation, and then tease it free of the blood vessels and other soft tissue there. And you can see it's starting to just come out on its own. There it goes. So this is a very satisfying operation in that when you take it out, you can see all the nerves relax. The operation altogether takes probably 45 minutes. People go to the recovery room and either go home from the recovery room or after a short stay in the outpatient surgery ward. To very quickly get to what the advantage of this is, I'm going to skip along here, give my colleagues a chance. What our research has done here, starting in the late 90s, was working with these minimally invasive techniques for disc herniation to see how fast people can get back to activities without compromising the outcome of the surgery. We did a quick trial back in the mid-90s with 45 working people to see if you encourage people to get up, be active as soon as you had the surgery. not to wait a long time, get back to doing what you need to do straight away, what would be the recovery time, and would there be more complications? What we found is that 90% of the people after the surgery went back to work, and the mean time that they were able to go back to work was under two weeks. This is compared to about 3 months as the usual protocol was 10 years ago. After we did this, it was tried to be replicated in other places, but people were still very leery of having people be that active after a spine surgery, even a microdiscectomy. And this was a study that was done in Scandinavia, where they thought they were being very aggressive when they were asking people to return to some activities at about 1 month after surgery. And their mean sick leave in that group was 3 months, and that was an improvement over the 4-month in the control group. What we did after that was to look at a larger group of about 150 patients and recommended that they start a walking program right away, get back to their activities as soon as possible. And during this time, I had some time in the Army, and we were able to get people who were paratroopers back to full duty in about 3 weeks. And most folks are not going to be doing that kind of duty, but we found in a civilian population it was just about as good. Now, looking at this is the return to work time. This is the postoperative sick leave in this 149 patients. Oops. And you can see that in patients, if you're involved in suing somebody about what's went on with your back, it takes you longer to get back to doing what you're going to do. Same with workers' compensation. But if you look here, the time to get back to full duty in heavy labor was 3.5 weeks. And this was 90% of the people went back to work. This is 90% of the people got back to work in 6 weeks. So it's a very good procedure. The microsurgery really helps people get back to activities, even heavy labor, in a matter of weeks, as opposed to when I was a medical student, when I was training, we really were keeping people out of heavy activities for 3 to 6 months. It's quite a bit different. And this chart is showing you the reherniation rate. And what it looks like is the reherniation rate is quite small. It's about 8%, 9% over 2 to 5 years. Not very high. Looking at the other way, 90% of the people, even going back to activities right away, 90% of people don't reherniate, even following them for 6 years. Well, thank you for your attention. I've been running a little late. I'm going to turn it over to Dr. Todd Alleman now, my associate.
So lumbar stenosis is probably a condition that a lot of people have heard about. This tends to be something that happens to people as they get beyond the age of about 40 or 50 in life. And as Dr. Carrigy was talking about some of the deformities we sometimes see in the hand, when we see an arthritic hand, oftentimes we'll see that the joints have gotten somewhat larger than they were when we were kids. And in the spine, when that happens, because those joints are arranged around the nerve roots, that can cause problems with pressure on the nerve roots. So that's typically why we see this problem later on in life, when the arthritic joints of the spine start to impinge upon the nerve structures running right past them. So what we see is, this is a scan of a motion segment in the lumbar spine, in which this is the disc in the front, and these are the 2 facet joints. Remember, Dr. Carrigy talked about the motion segment being the disc in the front and the 2 facet joints in the back. Those are arranged around the nerve canal, which is right in through here. And we can see that because this joint here has gotten bigger than it was, and this one here has done the same, they've started to impinge upon the nerve roots, which travel in through that central section there in the spine. So we see that the facet joints get larger, the disc gets larger, bone spurs form around the disc, and that causes pressure on the nerve roots at that spot. So that can happen in a couple of different spots. This is another cross-section through the spine. The disc is in the front here, and the facet joints are in the back. We can have central canal stenosis in the central part of the spine. That's typically caused by this ligament, which is defined by that little black line there, getting somewhat larger than it is originally. And then we can have lateral recess stenosis, where the nerve root, as it's getting ready to leave out to go out to the legs, gets pinched underneath the facet joint. And this is the more common part, or the more common type of stenosis that we see. When we talk about what sort of symptoms this causes in people, it typically causes them, as opposed to disc herniations, which bother people predominantly when they sit, lumbar stenosis bothers people predominantly when they walk. So what we'll see oftentimes in people who have stenosis is that they tend to walk with a progressively stooped forward gait pattern. The reason that they do that is the spinal canal opens a little bit as we all flex forward. So people find that as they walk, if they flex forward a bit, that relieves some of the pain that they have down the legs. They'll also find that if they are walking and have a lot of symptoms, leg pain related to their stenosis, if they sit down, their pain gets somewhat better. And we see exactly the opposite in people with disc herniations. So they present with a slightly different pattern. So is stenosis an inevitably progressive problem? One of the studies that looked at this was published in about 2001. About 400 patients were followed with lumbar canal stenosis. And in about 5 years, the patients that had surgery were generally better than the ones who didn't have surgery. But there were still a lot of patients in the non-surgical group who did fairly well. And this is why we try always to start out with a relatively conservative approach, as a lot of these people that have pretty severe symptoms will either not get much worse over time or spontaneously get somewhat better. And on the other hand, it is those patients that don't tend to get better with time that we end up treating surgically. So again, the overall natural history is somewhat benign. In people that have, as Dr. Carey was mentioning, a lot of muscle weakness in their legs, the natural history is pretty uncertain because most of those people typically get operated on. And it is rare for someone who has a severe muscle problem in their leg related to their stenosis to spontaneously get a lot better without surgery. So we typically wait for about 6 weeks when there is severe muscle weakness, and at that point we typically decompress them. So Dr. Carey went through some of the anatomy and talked about some of the traditional techniques of decompressing in the spine. There are some alternative methods of getting down to the pathology at hand to try to decompress things more effectively without disrupting the normal structures as well, as significantly. And these are a list of some of the things that we try to do. We basically try to preserve some of the normal tissue in the spine when we decompress the nerve elements. This has been investigated at a couple different spots. The concern had always been that it might not be possible to decompress the spine adequately without doing a complete laminectomy, taking all the bony elements off. And this gentleman, Dr. McCulloch, reported on several patients who had this done with a more limited approach, and his results were actually very good. Most patients who have an operation for spinal canal stenosis actually do very well. The rate of good results is expected to be around 85 to 90%. Again, the advantages to this approach is that we can still decompress the spinal nerve elements adequately and preserve a lot of the ligamentous structures and the bony supportive elements of the spine so that patients can get back to their usual activities a little more quickly. There are some newer alternatives for stenosis as well. One of the newer ones that's kind of interesting, which I thought we'd talk about, is currently under FDA trials and not approved yet. It was noted by some entrepreneurs that patients who have spinal canal stenosis are able to walk much longer distances if they flex their spine somewhat more forward. Because the spine is a connection of joints that are all connected up in series that we can't control independently, patients find that they have to flex their entire spine to get the desired effect just at one level. So a device was developed which positions one segment of the spine in flexion while allowing the rest of the spine to go into extension. And this has been under clinical trials over the last several years. And I can show you a little bit of what this does. So if we look at the spinal canal, which is depicted right here with the spine in extension, as the spine goes into flexion, tension's applied on the back part of the disc, And that makes it so that there's relatively a bit more room around the nerve roots. And it turns out that just that slight bit of increased room around the nerve roots tends to take people out of the symptomatic phase and allows them to move about without significant pain. This is a picture of the device, and we've got a picture of the device in place. So this is looking at a patient from the back. It's typically done under local anesthesia with the patient on their side. The patient flexes himself forward so that that spine is placed over that motion segment into a little bit of flexion. And then that device that we saw is placed in between these structures here, which are the spinous processes, those projections that come off the back of the spinal canal. Because those are behind the center of rotation of the spine, that keeps the spine from going into extension over that level. So they reported on their outcomes about 1.5 years ago, and it seemed that most of the patients, about 80% of the patients with this approach, actually do very well. They had a couple of complications related to their device, but overall things worked well, and the FDA is considering approving those at this point. So I'm going to go on to a second topic here, and we can get back to lumbar canal stenosis at the end if there are questions about that. But the second thing I was going to talk about is cervical problems. So up in the upper part of the neck, when, as Dr. Karagi suggested, there are compressive lesions in the upper part of the neck, they can cause one of two problems. They can either affect the peripheral nerve roots leading to the arm, or they can affect the spinal cord itself. So we'll start out first with pressure on the nerve root leading out to the arms. So people that have cervical radiculopathy means pressure on the nerve root itself and dysfunction related to that, tend to be younger, between the ages of 30 and 55. It happens more in women than in men, and it typically presents when there's an acute disc herniation in the neck with pain in the neck that rapidly evolves into pain radiating down the arm in a predictable distribution based on which nerve root is being impinged upon. Patients will have a variable amount of weakness or numbness and will guard their neck motion and tend to find that when they extend their neck, they have a lot of pain radiating down their arm. And sort of opposite of what you see with shoulder problems, they find that if they put their arm up higher, that tends to take the pressure off their nerve root and give them some symptom relief. And this is caused by the similar cascade that Dr. Karagi talked about, degeneration of the cervical motion segment, the joints, the uncinate joints, which are these joints over here on the sides of the spinal disc, develop bone spurs and can start to push into the nerve root where that exits. You see this on the other side right there. There can be compression of the nerve roots in the spinal cord directly behind the vertebra as the disc herniates out the back. This is a disc here in between the two vertebrae in the cervical spine. We can see that it's protruding out the back into the area where the spinal cord comes down, which is this area right in through here. As the spine ages, you can see that degenerative changes, those joints becoming arthritic and becoming larger with the development of bone spurs, really narrow down that space available for the spinal canal. And we can see the progression here from one side to the next. Again, the spinal cord itself is coming in right through here, and you can see that it's pinched most significantly right there. So this can be treated when the symptoms are severe and progressive surgically, and the most common procedure that we use for this type of a spinal condition, where the spinal cord is getting impinged upon over a segment, is to actually remove some of this bone from the front. In this case, it was between here and here. That, in effect, takes the pressure off the spinal cord, and then a bone graft's placed down between the vertebrae, and a plate's used to secure that into position. So you can see what's happened here. The vertebra and disc have been removed from this one here down to the other level. And then a bone graft is this structure right here, and then the plate's been applied to secure things into position. So these disc herniations and disc protrusions can also be treated from a different approach, from the back as opposed to from the front. And here's a little video of what that looks like. So you can see we're using a burr right here to expose the area around the nerve root. This is a probe that's being used to mobilize the nerve root. And we're going to see disc herniation underneath there at that point. The spinal cord itself is is over in this region here and is well away from the nerve root, which makes, or well away from the disc herniation, which makes this a safe procedure to perform. And these are bits of disc material coming out from underneath the nerve root, taking the pressure off the nerve root again. And then once that's completed, the nerve root itself is freed and can get out to the arm without seeing significant pressure. So here's another variant on this. This is a person who had myelopathy or symptomatic pressure on the spinal cord. She had a symptom that was going on for about 3 months of left arm pain and weakness. She also had some difficulty with walking, and she's relatively young for this condition. She's about 55. She's otherwise healthy. Walked with sort of a broad-based gait pattern. One of the problems that people will get into if they have problems with pressure on their spinal cord is they lose an ability to sense exactly where their foot is in space. So it becomes somewhat more difficult to walk, particularly at night, and they end up tending to walk with a broader gait pattern with shorter steps. And so we call that a myelopathic gait pattern. She also developed some weakness in her arms and some reflexes that we look for on exam that show that the spinal cord was being impinged upon. Here's her MRI scan, which again shows that the spinal cord itself, this structure here, is narrowed down over multiple segments in the neck. So she was diagnosed with having cervical stenosis, or pressure on the spinal cord, over multiple segments, and also a disc herniation as well. Lots of different potential treatment types for this. This is an interesting one that I wanted to talk about here. This is called a laminoplasty, where we basically create extra room for the discs and the bone spurs that have protruded into the canal by taking the pressure off the spinal cord from the back. This is a depiction of what happens. Here we can see the spinal cord is going to be this oval right here. The disc is in the front, and the posterior elements, the lamina and the spinous process, are here in the back. What we do in the laminoplasty is open up this space so that there's more room around the spinal cord. And we can see an x-ray of this here. This is the area that the spinal cord flows down through. This area between what we call the spinolaminar line, or the line in front of the posterior elements in the back, and then the line that defines the back of the disc and the vertebra in the front. So what we do in this procedure is open that space up, as we saw in the diagram, and that ends up increasing the space available for the spinal cord. And then we typically secure that in a position using several little plates, as you can see here. There's another view of her from the front. And patients typically do very well with this. We use them we put them in a hard cervical collar for about 3 weeks, and then let them start to begin their neck range of motion. Taper down to a soft cervical collar, and she's done well with this so far. So I'm going to turn the talk over to Dr. Ivan Chang.
All right, it's my pleasure to speak to you this evening about spondylolisthesis, which is the biggest word so far of the night. When you break down the word, what it means is spondylo in Greek means vertebra, and listhesis is to slip or slide down a slippery incline. So basically what we're talking about in the spine is instability or slippage of one vertebral body on top of another. And you can see on this side view of what is the lumbar spine, so the lower part of the spine, you see slippage of one body on top of another. And that is what's called spondylolisthesis. There's different classifications for this type of deformity, and I won't go into the details of that. These are a couple individuals that classified this type of pathology, but there are different types. It can be congenital, there are types where you're born with it, or it can be acquired and developed with time. And most of the patients that we see over in our clinic develop this type of deformity over time. This is one type called an isthmic spondylolisthesis, where there is an actual fracture or break in a portion of the bone in the back of the spine. And this can happen with a stress type of fracture. By 7 years of age, the incidence is about 4% of the population, which is not insignificant. So there's quite a number of individuals out there that have these defects. but the vast majority of these patients are asymptomatic. The more common type that we see is a degenerative or develops over time type of spondylolisthesis. And again, it causes instability between these motion segments that Dr. Carrigy spoke about. This tends to be more common in women. It's about 6 times as common, and most commonly occurs at between the 4th and 5th lumbar vertebrae. It also occurs more commonly when the most bottom part of the lumbar spine is somewhat fused to the sacrum. Won't go into the other details here. This can also occur after certain types of surgery. The types that Dr. Alleman spoke about, where we remove bone to take pressure off of the spinal elements, off of the spinal cord or the exiting nerve roots. If too much bone is taken away, you can actually create this type of instability, and you can cause slippage, which occurs after surgery. This talks about a little bit about the supporting structures in the back of the spine. Probably the details of that aren't as important, but again, what this emphasizes is that if you take too much of the bone away, too much of the joints in the back of the spine, you can actually through surgery, cause this type of instability. The natural history of patients who have a degenerative type of slip was studied and presented in 2002, where they had 25 patients that they looked at. And these patients had early instability, so a lot of movement at this type of slip, and had severe symptoms, but actually gradually had decreased amount of movement and decreased symptoms. In the end, they ended up with a narrowing of their disc space and osteophytes, or extra bone formation, which probably stabilized the spine over time. So when is the time to operate on somebody who has a slip? Again, somebody who presents with cauda equina, which Dr. Carrigy described, or which affect those nerve rootlets that come down at the bottom of the spine. If those are affected and patients end up with bladder or bowel symptoms, that is really a critical time to operate. Patients, again, who have severe motor weakness, that's another indication to operate. Patients who have progressive or disabling pain, which can develop with time. And patients who have gone through an extensive rehabilitation program but still don't achieve any relief of their symptoms. So there are basically 3 different strategies that we employ once we determine that somebody can benefit from surgery who has this type of slip. One is simply just to decompress or take the pressure off those nerve roots that are being pinched. Another surgical intervention would be to stabilize that segment that moves, which is usually entails a fusion. And the other type is actually reducing the deformity. So whatever slip is already there, trying to bring that slip back and properly align the spine and re-achieve proper biomechanics. Decompression, we have to determine where these nerves are being pinched, whether it's the spinal cord or those nerve roots that my colleagues described exiting, where it's being pinched. Typically for that isthmic type, which has a fracture, the nerves are pinched because of extra bone formation, a fibrous type of phenomenon. The degenerative type, or more arthritic type, tends to occur in the center of the spinal canal, and in which case we would want to decompress the spinal cord centrally. There are different methods of doing this. One type we use is, well, we like to do this in the safest and least destabilizing method, and I will show you a couple methods of doing that. What I'm going to talk about next is spinal fusions, which is one of the operations that we do for spondylolisthesis. Traditionally, this is an image showing what our traditional operations look like. Dr. Carrigy described when he was training, every incision was the same. It was, probably about this long, and you can see the length of incision here. That was the traditional open spine fusion. This tended to devascularize and denervate the soft tissues. Tended to cause a lot more blood loss than the techniques that we use today, and patients ended up staying in the hospital longer, took longer to recover, took longer to get back to work, and actually have probably more pain right after the operation than the newer techniques. One of the solutions, this is a specific type of retractor or instrumentation that we use. They're all different types, and this is just an example of one of the kinds we use, which is called a TAVI. And this is basically a tube that we put down. Instead of making a giant incision like we used to, making a smaller incision, and this tube actually expands within the muscles so that we can see through this tube. And there's less muscle stripping, there's less blood loss, and patients tend to feel better after this minimally invasive type of approach. And you can actually do this on both sides of the spine. You don't have to go right in the middle like we used to and strip all the muscles off the spine on both sides. You can actually use these tubes, one on each side, which is less destructive to the soft tissues in the back. So again, this tends to preserve the muscles and again dilates up. Similar to the tubes that Dr. Allman showed before, this is a dilating kind of procedure where you expand the area that you visualize instead of cutting through every muscle. This is an example using intraoperative x-rays, and you can see the spine over here with the tube coming down, and then once the tube expands, you can see what it looks like on the x-ray. It's actually expanded right above the spine and spreads the muscles apart. This is an example of using this tube during surgery, and again, instead of looking through a small tube, you can actually see it directly with your own eyes and don't necessarily need to use a microscope, although you can see better with the microscope. You can see a lot using direct visualization. Again, using direct visualization, you can attach a light to these tubes. It's really provides a lot of exposure through a small incision. These are just different types of instruments that we use to either help with the decompression, taking bone away, or removing the disc material. I'm going to kind of go through this. This is an example of decompression, or taking the bone away to relieve the pressure on the nerve roots, which we talked about. These are all different types of exposure, and just amounts to what area of bone you're taking away and how much bone you take away. And I don't think we need to get into the details of that, but you can see this is looking at the spine from the back, and this is the tube coming down and a probe coming down to show that the nerve that comes out of the spine in this area is relieved of pressure because we've taken bone away from this area. So you can see that this is intact bone on this side, and then this is where bone is taken away, and that nerve root ends up being much more happy without pressure from that area. This is a much more extensive removal of bone on this image here. And again, depending on how much bone you take away, you can destabilize the spine, so you have to be very careful on how much you take. I think this is a video showing an actual operation and taking that bone and pressure away from the nerve elements through one of these tubes. So this is actually using electrocautery, using electricity to stem some of the bleeding which occurs during the operation. This is just exposing more of the bone, and we use a high-speed burr to thin down some of the bone that covers the nerve elements, and that's what you're seeing there. So just to orient things, I'm sorry. This is taking the bone away using special types of punches, and I apologize, this is a little off view, but what you see here, this is, again, bone here, and then this is that hole that we've created, and the nerves actually traverse through this region. There are other techniques. Even through these tubes, you can actually put bone grafts into the spine to facilitate fusion. So there's a lot that you can do through these tubes, not just taking bone away, but you can actually perform a fusion through these tubes as well. These are types of bone graft that we use, and this is an example of going through the tube, pushing that bone graft in to help stop the motion segment from moving and creating a bony fusion. This is an example of using the tubes to place screws, which is what we use in certain cases to facilitate a fusion. So the basic concept behind a fusion is to stop a motion segment which is suspected to be painful or unstable and stop that from moving. So what you're doing is you put a piece of bone in, or you take bone, whether it's from the patient themselves or allograft type of bone, which is a cadaver bone, and stopping that from moving, and that bone kind of melds the bony elements of that spine together, kind of knits it together, and screws can help stop that from moving while that bony elements are fusing, while they're healing together. The screws can help stop the motion, and it's just like gluing two pieces of wood together. While the glue is setting, you put a vise on to stop any motion so that glue can set. That's what the screws and rods do. They stop motion there so that the bone can heal in. And this is an example of just putting the rods through the screws and using it through the tube that we showed previously. This is just a different system, just to give you an idea of a different type of system that we use. And you can see here, screw placement can actually be done very minimally invasively and through very small skin incisions. You can see that there's a small skin incision there, small one there, small one here, small one here, and small one here, rather than one long midline or centered incision. You actually kind of put these screws right through the skin, and there's an entire system to do that. You use X-ray to place these screws through small incisions, which you can see in the patient here. And again, this is placement of the screws. You can see the screws going into the vertebral bodies. This is a side view of the spine. Here's a vertebral body here. This is what we call a pedicle, which is a bony process right here, and the screw is going right through there. And we do this all through X-rays, and this is all you see on the surface, are these screws going through the skin. So X-ray is critical when you're doing this type of system. These screws then attach through these extenders, and the extenders help guide a rod through the skin into the rods without exposing any of the spine along the way. So here is the rod actually going through with an arc, and it's going to end up in the screws. And here you see, let me see, get the arrow going here. Here's the rod, and it's gone through the skin and now is seated in the screws. And this is all through those small incisions. So finally, this is what it looks like in the end. Again, the very small skin incisions. You have the screws in place and the rods in the screws holding everything together and stopping that motion segment of the spine from moving. One thing that's a particular interest to me, and I'm sure all of you know, either have family members or who have friends who have younger patients who have scoliosis. And one of the developing techniques is using these minimally invasive techniques to treat scoliosis. I'm going to talk a little bit about a certain type of scoliosis, and that's adolescent idiopathic scoliosis. And that tends to occur in the young adolescents, tends to occur more in girls than boys who are before their menses, and it's a very common type of deformity of the spine. Again, scoliosis is a complex three-dimensional deformity, and not only is it curvature, which if you look at somebody, have curvature when you look at them from the front, but there's also rotation of the spine, which is why if you see school screening for scoliosis, we have the kids bend over, and what you see with scoliosis is one side of the ribs is higher than the other, and that's the rotation that we're looking at in scoliosis. So the angle of the spine, what we measure, is defined as more than 10 degrees for scoliosis. And again, it can occur most commonly from age 10 on to skeletal maturity. And the rate is about 25 per 1,000, which when you think about it is very, very high. And this includes all comers. This is everybody who has a curve more than 10 degrees. So that's quite a few individuals out there have scoliosis. Again, the ratio is about 1.4 of females to males, and tends to be even more weighted towards females when the curves are bigger. When a curve is greater than 30 degrees, the female to male ratio becomes 10 to 1. Why that is, no one knows, and that's why we call it idiopathic, because we don't know. There tends to be a hereditary pattern. 7% of siblings have this type of deformity, and anywhere from 6 to 14% of patients who have scoliosis, their parents also have scoliosis. And this is an example of siblings here. Here's the older brother and here's the younger sister, and both of them have scoliosis, and hers looks worse than his. And you see that rib hump that I was talking about, which she has much more prominent on the right. So what we examine for these patients, we look at their shoulders, we look at their chest, see if there's any asymmetry there. We feel their pelvis and make sure their pelvis is also symmetric. You can look at skin folds from the back to see if there's asymmetry there. It's very important to assess these patients for how much growth they have left in their spine, which determines what kind of treatment that they can receive. So you look at secondary sex characteristics, and you also want to look at the patient from the side, because they can develop other deformities, not just curvature when you look at the front, but they can actually develop curvature when you look at the side as well. Other tools we use, and this is something that a lot of pediatricians use, is a scoliometer. And what you have is the patient bend over, and what we do is rest this instrument right on their spine. And you can get a rough estimate of how much rotation they have there and how severe their scoliosis can be. And this is a general screening tool that is used in a lot of pediatricians' offices and even in schools. This is an example of what scoliosis looks like on plain x-ray, and this is the full length of the spine looking at the back of the patient. So their head is up here, and you see their pelvis down here, and you see this 54-degree curve, which is not insignificant. Even at 54 degrees, however, a lot of patients can hide this pretty well. If patients wearing regular clothes, you wouldn't even notice if somebody had 54-degree curve necessarily. And this is in a 15-year-old. So really, there are only two treatment options that have been shown to make any difference in scoliosis, at least adolescent idiopathic scoliosis, and that is bracing and surgery. Bracing, this is an example of a type of brace that we employ, which basically wraps around the patient. It's custom molded so that there are pressure points on the spine to try to correct the deformity. And you get x-rays in these braces, and the patients actually look remarkably good. The goal of bracing, however, is not to correct the curvature, but to prevent progression. Because in the end, once you take this brace off, these patients tend to fall back to their original curvature. So you're not trying to correct the curve, you're just trying to prevent it from getting any worse. And surgery, when it comes to that, obviously can arrest any further progression of the curve. This is an example of a type of surgery that we do. And you see this is a 74-degree curve in a patient who's 13 years old. A rather large curve here, and what we did is, just going from the back, we put in screws and rods in the back and bone graft on the sides to fuse the spine. So that part of the spine, once it's fused, will never move again, but the curves should never change either. And what we're trying to prevent is progression of these curves when these patients get older. And a lot of these patients who have curves over 40 degrees or so, 45 degrees, end up progressing about 1 degree per year, which doesn't sound like a lot. But when you're talking about a 12 or 13-year-old who has 70 years left of growth, or of life left, that's 70 degrees, which is not insignificant. And so what you're trying to do is prevent that from happening. And this is what we calculated, 97% correction. Really, we reduced the curvature to only 1 degree after surgery. Now, one of the techniques that we're talking about, minimally invasive, we can actually use, similar to doing a knee arthroscopy or shoulder arthroscopy, we can stick a scope into the chest and perform certain procedures on the spine. And we can take out discs, we can even put in screws through these scopes and very small incisions. And the goal, the advantage of this type of surgery is, again, smaller incisions, less blood loss, they tend to have less pain. Potentially they have better lung function because you don't make a big incision in their chest and take out the rib. And they have shorter hospital stays. And really what we're seeing is no difference in terms of the fusion rates. The disadvantages are there's a very steep learning curve for the surgeon. This can be a technically very, very challenging procedure. Takes probably anywhere from 2 to 3 times longer for the surgery than you would do open. And potentially there are very severe complications when you do it through these minimally invasive techniques. If you can imagine, if you encounter significant bleeding in a case like this, it's very difficult to control. So there's potentially very severe complications. This is an example of one of my cases where we corrected a 15-year-old who had a 55-degree curve, which you see here on the left. And we put all these screws in and this rod through small incisions and facilitated with a scope, thoracoscope. And you see the goal is not necessarily correction, but balance for this patient. And you can see that their shoulders and their pelvis in this view right here are very well balanced. And the curve above and the curve below are very balanced. And that's really ultimately the goal. And this was done through small incisions, and this is actually that patient. This is before her operation, and after her operation, there are 4 incisions right here that are probably about 1 inch each. And instead of staying a week in the hospital, week to 10 days, which a patient like this normally would, she actually went home on postoperative day number 4. So she was only in the hospital for 4 days, and she did very well. So in conclusion, this was a very broad overview in a pretty short amount of time, but pathology in the spine can cause very significant symptoms, and typically it can be very focal, can affect certain nerves in a specific way, and there are specific diagnostic techniques that we use to detect these. The bottom line is the vast majority of patients who have all of the pathology that we talked about, all these different types of spinal problems actually respond to non-surgical treatment. And that's one thing that we'd like to drive home, is not everybody who comes in needs surgery, and we try to treat people as conservatively as possible, and when it comes to surgery, if they need it, we try to guide you through that process. Surgery, if necessary, really should be directed right at wherever the problem is, and that is one of the most difficult things to do in surgery, is determine where the most local problem is. And the goal of minimally invasive surgery is really disrupt normal tissue as little as possible, and can be very successful when it's properly planned and carried out in a technically sound fashion. And that is the end of our talk. The question was, if somebody has some sort of implant like a pacemaker and cannot receive an MRI, can we get information using other techniques?
So that happens a lot. People have, for instance, aneurysmal clips or pacemakers that aren't compatible with MRI scanning, and we run into that frequently. So what we can do is, first we have to figure out exactly what it is that we want to determine. Some things we can figure out very well with X-ray. For instance, if we're looking for instability in the spine. So we do dynamic X-rays with the patient bending forward and leaning back, and can get our information that way. To look at the pressure on the nerve roots in the spine, which is usually what we use an MRI scan for, we typically will get what's called a CAT scan myelogram, where a myelogram is done, so dyes placed into the spinal fluid around the nerve roots, and then a CAT scan is done. And that gives us actually very good information. The question is whether or not that's equivalent to an MRI scan. It's not quite as good for looking at disc processes, but for looking at stenosis or problems related to that bony hypertrophy or the increase in size of the joint, it's actually very good. And in some cases, it's actually better information than an MRI scan would give. So if we look for bony detail, the CAT scans are a lot more useful sometimes than the MRI scan.
There were 3 questions. One is, are these procedures experimental? Some of them are, and I think Dr. Alleman talked about an FDA trial in the spacer for the back, and that is still in an experimental stage. There are other procedures, like some of the procedures using the tubes, that are being done in clinical trials in a random fashion. So you could get A or B if you enter the randomized study, but the equipment's available anyway. In other words, are these procedures?
Locations other than Stanford?
Are there locations other than Stanford? Sure. From the most basic, that is simply using a microscope to do a disc herniation surgery, that is widely used. Most community hospitals have some sort of magnification system. Certainly many university hospitals are running similar trials to what we're running here. And the third question?
Who are the best candidates for these types of procedures?
Well, it really depends. We talked about like 4 different types of pathology. Probably the most commonly applied is for a disc herniation. And although people can certainly do a very good operation without using a microscope or specialized instruments to retract, we here feel that you get a better result using at least better short-term result using these minimally invasive techniques. So I would say the most common, widely applied thing is for a disc herniation. But the things we've been talking about are some of the more cutting-edge stuff of doing a fusion using the microscope, of doing spinal stenosis surgery using a microscope, even doing scoliosis operations using scopes as well. The first question was, what am I talking about when I'm talking about paralysis with a herniated disc? Strictly speaking, a paralysis would mean that the nerve that's being compressed may stop functioning altogether, or some degrees of stop functioning. So if it stops functioning and it results in weakness, then that could be a partial paralysis or paresis or a complete paralysis. Now you can, with a herniated disc in the neck, you can have a complete quadriparesis. That is, you could have a complete quadriplegia. The further down you go, the less nerves there are below where the disc herniation is. So when you get to the very bottom, then you can have some weakness in your foot or some bowel or bladder paralysis. It varies all across the board. And the second question was on what's a thoracoscope?
Oh, I actually have a mic, thanks. The thoracoscope actually is used for other types of problems in the spine other than scoliosis, and that's a good question. It tends to be focused on for scoliosis in these younger patients because they can tolerate this type of surgery and lengthy procedures and things like that. But it actually is being experimented with in any type of fusion, any procedure that requires a fusion in the spine and need to go in the front of the spine, in the chest. People are using it for tumors, for trauma, infections, and it can be used for anything that requires fusion in the front of the spine. So it's not specific just to scoliosis.
So the first question is, can the procedure be done without a general anesthetic, if I've answered that appropriately? So it sort of depends to some degree on what the problem is. If, as Dr. Carrigy was talking about, the problem is that there is a disc herniation or a single level that is stenotic, for instance, that can be managed anesthetically in a number of different ways. I've done that sort of thing under local anesthesia only with the patient awake. It can be done under a spinal anesthetic with the body from sort of the chest down numbed down, but with the patient still awake. Or it can be done under a general anesthetic. And the decision of which of these approaches we take is based on a couple of different things. Some people, frankly, don't like the idea of being awake when their spine's being operated on, and yet other people, if they have, for instance, problems with their lungs or other things that might put them at greater risk for a problem with a general anesthetic, would rather have the operation done under a local or a spinal anesthetic. Some people that use their voice professionally, for instance, an opera singer, would typically want to have that done under a spinal anesthetic rather than a general one. So that can be accomplished in a lot of different ways. The question is, what does lack of success mean? In other words, if someone has a spine operation, what are potential reasons that it might not work, and what does that mean for the patient at hand? So if we look at large numbers of people that have surgery for spinal canal stenosis, if we look at them about 10 years later, by the time we get to about 10 years, about 30% of those people are having problems. And the typical problem that someone has after a spinal stenosis surgery is one of progressive back pain. So typically the surgery is done for leg pain when they're up and about walking, and yet some people 10 years down the road, one group will have problems with back pain. We feel that some of that may be related to the surgery itself, the amount of dissection that's done, and we feel that some of these newer approaches, while not tested 10 years out, because they haven't been around for that period of time, might be able to minimize some of that downstream trouble that people can have after a surgery for this sort of thing. Some other people, as we mentioned, could have perhaps too aggressive a decompression done. In other words, too much of the supportive structures have been removed, and they could develop instability or problems where that joint isn't working appropriately. And then on the other hand, some people could have had not quite enough tissue taken out surgically, and they could have the problem come back. The things that we worry about surgically, intraoperative complications, so people who have the nerve roots stretched too much in surgery or damaged in surgery, those problems are pretty rare. So the problem is typically one of either too much decompression being performed, too big an exposure being performed, or maybe the pathology, in other words, the compression of the nerve hadn't been completely freed up at the time of the operation. So that's kind of a potential problem with technique.
I think I could add something else to that, in that we've been doing work here on whether the surgeries meet patients' expectations, and that being a benchmark for whether the surgery is successful or not. And in surgeries for lumbar disc herniation and in surgeries for spinal stenosis, the likelihood of someone coming to surgery with these types of operations and meeting their goals in pain relief, return to activities, the amount of medications they take, and a general satisfaction with the surgery, of meeting all of those on every parameter is about 70%. So about 70% of people meet all of their goals. If you lower it to how many people have a 50% relief of their back pain, you can get those numbers up to 90-something%. So depending on how you're defining success, it can be somewhere between 70 and almost 100%. There are artificial discs that have, just as of this past October, been approved for general usage. At the same time, there's been some studies done looking at what percentage of people who have spinal surgery would be candidates for disc replacement surgery if you use the criteria that are put out by the manufacturer and the FDA. And it looks like, from a big study done in New York, that only about 2 to 5% of people having surgery on their spine are eligible if you go by the criteria for what disc replacements could be used for. The studies that have been done comparing fusion, randomized studies comparing fusion to disc replacements, so far show that they're about the same. That is, the results at a year, and I believe also the results at about 2 years, are about the same for a disc replacement type surgery at 1 or 2 levels compared to a fusion at 1 or 2 levels. The problem is, if you put an artificial disc in someone who's 40 years old, that thing has to last forever from that person's point of view. And we don't know that. On the other hand, we have a pretty good idea what happens with a fusion, because we have a lot of experience with that. And with a fusion, it looks like over about 10 or more years, about 15% of people will have problems at another level. Whereas we really don't know if the materials will hold up, the bearing surfaces will hold up, and all of that. That's pretty new stuff, and at least in my mind, it's still experimental stuff. The question was, are we doing any of the total disc replacements now? We have not. We are looking into it. We're trained up to do it. I don't know if you've gathered from the gist of our conversation here that we are a relatively conservative group. And at least speaking just for myself, I would like to know that these discs that are being put in people will work well 5 years down the road. I think if it were my family, I'd want them to know that as well.
As far as your other question, you asked if it was being put in more than one level. That is not FDA approved right now in the United States. However, they have been putting in discs in Europe and South America a lot longer than we have experience here in the States. And their initial data seems to be promising. I mean, I've seen examples from Europe of 2, 3, 4, even 5 levels of disc replacement, which sounds a little extreme. But I think what we really need to see is long-term data, because we need to see what happens 5, 10, 20 years down the line, not just 1 or 2 years. And that's what we're waiting to see.
The question was, do herniated discs become symptomatic slowly or all at once? Well, actually, it can be either one of those. The sciatica, pain down the leg, can come on slowly. It can also come on very abruptly. Probably, to answer your question in a broader sense, probably most people with a disc protrusion never have any symptoms. Most people who have a herniated disc never have any symptoms. So if you look at an MRI scan of people in their 50s who've never had back troubles, about 40% of them are going to have disc bulges or prolapses or stuff like that. They very rarely will have enormous disc herniations. But, and on the other hand, it is very unusual for a normal disc to herniate with usual activities. So that if you lift up a waste paper basket or get your kid out of a car seat or do some gardening and you get sciatica, it is very, very, very unlikely that you had a normal disc before that. That event was probably the last straw of something that's been going on for many years. And it's the idea that, oh, I shouldn't have done that is, in my opinion, ridiculous, because sometime in your life you would have had to twist that way, and it would have come. The question is, if someone has an arthritic spine with backache, is yoga a reasonable thing to consider? I think obviously everyone's different, but I would say in general that if someone has backache with arthritis in their spine, no neurological problems, nothing else bad going on, I would tell them to be as active as they can be in the things that they enjoy doing. If you enjoy doing yoga, I wouldn't say because you have backache and a arthritic spine that that's a reason to not consider that. I would say to stay as active in the things that you enjoy as possible. The data is actually very good that people who stay active and fit do a heck of a lot better than people who try to limit their activities to avoid backache. There's not much good data on yoga.
The question was, will there be any change in the treatment of cervical stenosis over the next 5 to 10 years? Certainly, every year the operative microscopes get a little bit better. General anesthetic gets a little bit safer. So those sorts of things in terms of the experience of the patient, I think things become a little more tolerable each year. Whether or not there's any sort of phase shifts coming over the next 5 years, a little unclear. There's some disc replacements that are under consideration in the cervical spine, and out there on the extremes, they're being used for cervical stenosis after decompressions of the spine. In other words, where the disc is taken out from the front. Some people are experimenting with putting structures in the spine that prevent the spine from having to be fused over that segment. Now, that may turn out to be a bad idea, and it's not clear yet, but that's certainly something that may change the way we treat people with cervical stenosis down the road. Now, most people with an arthritic spine that have developed cervical stenosis really don't have much motion over those segments that are stenotic anyway. So my sense is that that's probably not going to offer a real significant improvement over the current treatment, which for a lot of people with cervical stenosis involves taking the pressure off the spinal cord from the front and then doing a fusion over those segments.
And what Dr. Alleman is focusing on is the central type of stenosis, or narrowing around the spinal cord. If there's narrowing around where the nerves actually exit in the neck, there are techniques being developed using those tubes, very similar like we talked about in the lumbar spine, using the tubes in the back of the neck. And actually we showed an example of that, doing a decompression of nerve root through the tubes, and that's, I think, something that's probably going to catch on a little bit more in the neck as well.
The gentleman described a complex failure of 2 surgeries to relieve his pain in his neck and in his arms. And that's a good question, and it points to the problem with the progressive degenerative problems, and the idea that there are many, many ways people can suggest to fix these things. The question is it prudent to do these things or not? Are there reasonable expectations of outcomes for many repeat surgeries? And we certainly can't give you individual advice on this without knowing everything, but I would say in general, the best chances to make stuff better are the first time. Multiple failures become more and more difficult. On the other hand, if there are absolutely specific, clear, bad things going on now, then they may be able to be addressed. But if people keep looking in there and scratching their heads and saying, well, I don't know, maybe this will help, maybe that'll help, I would head for the hills. Unless something is very clearly a problem. The question was, is the severity of a first-time disc herniation, does that impact the risk of future herniations? And that's a great question, and there's a good answer for it. That is, it's not so much the size of the disc herniation that seems to predict further disc herniations. It's how much of the annulus, that is the wall that contains the disc, how much of that remains intact after the herniation and after the surgery. If the herniation blew out most of the back wall, the reherniation rate is quite a bit higher. If instead it slipped out through a slit, then the reherniation rate is very low, like 1 or 2%. So at the worst extreme, where there's no back wall left, the reherniation rate is probably over 20%. On the other extreme, if it came out through a small slit, the reherniation rate is probably under 5%. Thank you very much.
Thank you.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.